So overall, the buprenorphine maintenance seems to be much more effective than this taper detox. Buprenorphine formulations, how does it come? So you have buprenorphine and Suboxone, right? Suboxone is the film. It's like a little square or rectangle that you can put in the like the cheek area, and it like, basically dissolves. It also has naloxone in it too, to prevent like things like overdose and things like that. But this, I don't know if it's here, the Subutex, I believe is like um, different tablet, maybe like one of these buprenorphine tablets. I think there's some more that are not on here, but that's another one that's used tablet. I think we use that to start off, and of course you can do like start at like 4 milligrams, etc. For example, go up by 2 a day or something. Monitor them every couple hours and maybe go to 8, etc. So that's something that we can do with the buprenorphine. Now this is kind of a new one. I don't know if we have used this before, but it's Sublocade. It's actually a buprenorphine injection, 100 milligrams per month. I have not used it before, but I've heard of it, and another doctor that I met in Austin does use it, and he likes it a lot because it's a once a month thing, so it's less time and less like taking time out of your day, and it's easier to do for the patients. But um, you have to get to that point. So, um, and I believe that's like a picture of the giving the injection. Maybe one day we can do that, but we're not there yet. And I don't believe there's something like this for methadone. I don't think there is, just for Suboxone. Anyhow, buprenorphine efficacy summary. So this is study, research, randomized control trial research show that buprenorphine 16 to 24 milligram is more effective than placebo, which is like nothing or detoxing, and equally effective to moderate doses 80 milligrams plus of methadone on primary outcomes. So buprenorphine and methadone are equally effective as important retention treatment, abstinence from opioids, decreased craving, decreased mortality, decreased death, improved work, improved psychosocial outcomes. Multiple studies show that. Okay, treatment gaps following opioid use disorder. Okay, less than 1/3 of opioid overdose survivors receive medication for opioid use in subsequent 12 months. That's bad, right? Everybody who's overdosed in ER, Providence, right? Thomason, UMC, um, all these hospitals, Palmas del Sol, everybody should get a referral to us, right? But that doesn't happen. Receipt of medication for opioid use disorder was associated with decreased all-cause opioid mortality. So decreased death. Remember we talked about decreased death, decreased overdose, improved job, improved finances, improved mental health. Okay, overcoming my fear of treating opioid use disorder. So I guess this is another case. Dr. Pugh is reluctant to obtain waiver to prescribe buprenorphine. Lost final or so caring for these patients. So this is, I think, just some personal experience from a doctor that gave a present, who did some article about this. So it's true. Not treating this or is not recognizing it. Of course, it's not necessarily a positive thing. Not something to be proud of in our community that we have a big opioid use addiction problem. That's not something that we're proud of, but it's something we should recognize. It's something that we should try to treat. It's called like harm reduction and recognition and acknowledgement of what this is. Any help with patients and all those things. Starting medication for so different places can do this for patients. So sometimes you get referral from like Providence or UMC Thomason where they sometimes may even be started on methadone, right? May even be started, or they had a detoxification program. But I think they use methadone more than buprenorphine. Anyhow, or UBH as well. Sorry, buprenorphine treatment is effective for medically patients who are not seeking addiction treatment and reduces illicit opioid use. So they have, excuse me, actually at UBH and also Mesilla Valley Hospital, where I work, for the inpatient, meaning like they're staying there 24/7 for like 7 days, have round-the-clock nursing. We do have buprenorphine detox protocols, which is like 4 or 6 milligrams first day, and then like goes down to maybe it continues maybe for 2 days, and then like goes on to 4, and then goes on 2, or and then goes down like very gradually over a week, and then it goes to 0. So that is something that they can do. Emergency department initiated buprenorphine treatment, brief intervention, and referral significantly increased engagement. So they can start in the ER, although I think that's not as popular here. but it's something that that could be done. Now, opioid agonist treatment and acute pain management. So can be a little bit challenging. Someone has this, and but I think like Eugene said multiple times, Aliviana Clinic method medication assisted treatment opiate treatment program is not a pain management clinic. We're not pain doctors. We are not pain counselors. I'm not a pain doctor, right? Um, I mean, we can maybe help with the opioid use disorder if they have a concurrent or at the same time pain management problem, but methadone, buprenorphine are not to be used for pain management. So sometimes you have people, so we need to distinguish that. And sometimes if they have both condition, we have to talk to their counselor or their physician, doctor who is a pain doctor and pain counselor to make sure we're on the same page. Patients who are physically dependent on opioids must be maintained on daily equivalents before any analgesic effect is realized. Yeah, so they must be maintained and not be in withdrawal, and then they can be treated. But realistically speaking, opiate treatment used for treatment of pain should be used for either like a few days acute pain, surgery pain, or cancer pain. Like it shouldn't be used for like headaches and stomach aches and mild sprain of bone or muscle. Opiate analgesic requirements are often higher due to increased pain sensitivity and cross tolerance. So basically, they need more opioid. And that's all I have for tonight, folks. So thank you so much. And I'm sorry that I could not be in person, but I really appreciate it. And thank you very much. You can have questions.